Hello everyone, this is Dr. Sheenam Bansal. So today we will do the distal humerus fractures. Okay, firstly we will do the classification. In the any fracture, there are two most important things, that is classification and management for the examination purpose. Firstly, we will do the AO classification. For distal humerus, firstly it is humerus so 1, distal humerus so 3, A1, A2 and A3. Avulsion, simple and wedge fractures. You can remember it in the alphabetical order, is avulsion, simple and wedge. Then there is B1, B2, B3, lateral sagittal fracture, medial sagittal fracture, frontal plane. B is the partial articular, C is the complete articular, A1, A is the extra articular. C1 is the fracture in which there is simple articular and simple simple is a metaphyseal. Simple articular and simple metaphyseal. But in the C2, it is also called C1 is also called T shape. C2, what is the simple articular? But there is a fragmentary. There is a multiple fragmentary metaphyseal. In the C3, there is multiple fragmentary articular and multiple fragmentary metaphyseal. So there is also Milch classification. In the type 1 Milch fractures, there is lateral trochlear edge which is intact. There is watershed area in between the capitulum and trochlea. In the in the management, we will do the non-operative in the Milch 1 fractures. In the Milch 1, lateral trochlear edge is intact, but in the Milch 2, it is not intact. Fracture line is passing through the trochlea. So in the Milch 1, you can apply the cast. So operative treatment is done in all uh, other fractures. Triceps splitting approach is used, that is also called Campbell. Triceps sparing, olecranon osteotomy, that is also called chevron osteotomy. The disadvantages with the olecranon osteotomy is that you have also to fix the olecranon fractures which you are iatrogenically causing it, and it there may be non-union result in it may also result in the non-union, and it may also damage the AIN, anterior introitious nerve. Okay, anterior introitious nerve, supply FDP, FPL and pronator quadratus. So you will have to flex the thumb. You will face the difficulty to flex the thumb thereafter if you have AIN injury. Then there is tricep reflecting approach. This is also called Brian Murray approach. You can see reflecting Brian Murray. RR is there, and there is also trap approach. That is tricep reflecting and conus pedicle. That is also called O'Driscoll approach. Now, see, you have the two management principles, that is AO and O'Driscoll. O'Driscoll is usually used in the osteoporotic patient because it is mainly based on the closed arch principle. In the AO, you mainly AO says you have to keep the screws as minimum as possible, but O'Driscoll says you have to use the maximum number of screws so as to make the closed arch configuration. So second difference is that AO says you don't have to pass the intercondylar screws from the plate, but means it should be outside the plate. But O'Driscoll says intercondylar screws should be passed through the plate so as to give the closed arch configuration. And third is O'Driscoll is mainly done in the parallel configuration. Okay, parallel configuration plates are applied, but in the AO you can also apply in the AO parallel or 90-degree configuration, but mainly 90-degree configuration plates are applied in the AO. So mainly O'Driscoll, the principle is you have to make the closed arch by using maximum number of screws, and one O'Driscoll also says your screws should be so bigger so that it can also engage the opposite fragment. Okay, so these were the O'Driscoll principles. This was all about the distal humerus fractures. Thank you so much.